Many times medications aren't enough, or they can't be tolerated, or they can't be put in the eye on a regular basis. And people have to go to surgery, be it incisional or laser. And again, the treatments that we're talking about are all about lowering intraocular pressure. That's the only proven way of protecting eyes that have glaucoma. So there are going to be a number of approaches that's going to be talked about by our next speaker using laser and surgical ways of lowering intraocular pressure. So Dr. Brian Schaefer is our next speaker. He's the founder and CEO of the Schaefer Vision Institute here in Philadelphia. He's adjunct assistant professor of ophthalmology at the Perelman School of Medicine, University of Pennsylvania, and he's going to talk about lasers and surgical options. Brian?
I'm curious who here has a reliable plumber that they can call on a Saturday. I just found my own, and he actually happens to be my own patient. And I'll tell you, as Dr. Vora said, all we really are as glaucoma specialists are plumbers. We're eyeball plumbers, and we can do plumbing using medications, but oftentimes we have to go beyond, and we have to use our hands to make a difference in your eyeball. My name is Brian Schaefer. I'm a cataract, refractive, cornea, and glaucoma surgeon. I have my own practice, Schaefer Vision Institute, as well as some academic affiliations. And my goal in my practice is really to provide that university caliber care in an intimate private practice setting. I know that many of you go to the doctor and you sit in that waiting room for a long time. You wait and you wait and you wait some more. And my goal with starting the practice was to sort of take some of that waiting and some of that experience out of it, because it's very nerve-wracking to go to the eye doctor. It's even more nerve-wracking to go to the eye doctor when you might need surgery. So at SVI, our goal is to help relieve some of the anxiety associated with having to have eye surgery. These are some financial disclosures. I do speak and consult for some of the companies that we use our products on. So what happens if we're overflowing? I just moved into a new house about a month ago, and the first weekend this happened. I happen to have a 4-year-old, so I'm going to leave it up to you to guess what happened. But the reality is that glaucoma is no different. As Dr. Vora mentioned, we use this analogy a lot of, is the faucet on too much or is the drain too closed? If that's happening, we have two options. We either turn down the faucet or we open the drain. But the eyeball's different. There's nowhere for the fluid to overflow. It can't go anywhere. So it's like overinflating a basketball or a balloon. What happens? The pressure goes up. So our goal, surgically or medically, is to relieve that pressure by either reducing the amount of fluid that's being produced or by increasing the amount of fluid that's being drained. As Dr. Vora really eloquently explained, this is a model of the eye. All of the fluid in the eye is produced in what's called the ciliary body, and it gets drained through what's called the trabecular meshwork, and ultimately gets drained into the veins that drain the blood from the eye. The glaucoma journey for every patient is unique. But as we know, the only thing we can do to prevent glaucoma from getting worse is to lower the pressure inside of that eyeball. You'll hear later today about all sorts of research that's being done to hopefully make it so that we have other things we can modify in a patient's glaucoma journey other than pressure. But right now, at this exact moment in time in 2024, all we can do is lower the pressure. And in an individual patient's glaucoma journey, we often use medications, lasers, and surgery. And over the lifetime of a glaucoma patient, we tend to do all of those things. I'll ask you, which eye is getting those eye drops? It's kind of obvious, isn't it? It's also a little unfortunate that this is the reality of a lot of our eye drops. Although it's relatively straightforward to put eye drops in your eye to lower the pressure, relatively, not simple, but relatively straightforward, they're not risk-free. This is not an uncommon appearance of an eyeball that has been on a prostaglandin, like latanoprost, for a really long time. And this has led to what Dr. Vora was just mentioning, this concept of interventional glaucoma. Interventional glaucoma is the early detection and treatment of glaucoma by utilizing lasers and procedures to lower the pressure inside of your eye without relying on the use of eye drops as the primary therapy. I'm curious, who here started their glaucoma journey with a laser procedure? That's wonderful to see, and that is becoming much more commonplace. We're going to talk about that again in a moment, but I love seeing all of those hands go up. Let's talk about the freaking laser beams, because lasers are awesome, and in ophthalmology, we're lucky that we have the ability to use a lot of different kinds of lasers. And in glaucoma, we use a couple different kinds. But before I get into this, I want to remind you, there are really only two ways that we can lower the pressure inside of an eyeball. One of them is by turning down the faucet, and one of them is by opening up the drain. So as we talk about lasers, we're going to start by talking about ways that we can open the drain, and then we're going to talk about ways that we can turn down the faucet. There are really two main general classifications of glaucoma. There's open-angle glaucoma, which I would bet the majority in the room have been diagnosed with open-angle glaucoma, but there's also closed-angle glaucoma, which I would bet a couple of you have as well. In open-angle glaucoma, the drain of the eye is open and visible, but it's clogged, not working. In this situation, we use a procedure called SLT. Who's had SLT? Most of the room. That's awesome to see. SLT is where we use a laser to target the trabecular meshwork, which remember, that's the drain of the eye. That laser targets the trabecular meshwork, and what it does is it actually creates a little bit of inflammation. And that inflammation brings in these little cells in our body called macrophages. And what those macrophages do is they chew up all of the debris in that trabecular meshwork. I kind of think of it like Drano. The drain is clogged, that laser is like Drano. I'll get to this in a moment, but SLT is rapidly becoming a first-line therapy for glaucoma. Before we get into why that is, I'm going to mention the other type of laser that helps open up the drain. This is a laser peripheral iridotomy, and this is for closed or narrow angle glaucoma. Has anyone here had an LPI? Yeah, a couple people in the room. LPI, or laser peripheral iridotomy, you can see this little hole on the iris right here. We use a laser to poke a hole in the iris, and the purpose of that is to reorient the eye so that the drain opens up. That's like if the drain cap is closed and you lift it up. Now, that's a less common thing here amongst a group of open-angle glaucoma patients, and we can talk about that later. But for right now, let's jump back into SLT, and let's get an understanding of why this has become so common as a first-line therapy. Everything we do in medicine has to be evidence-based. Otherwise, we're all just making it up. In this situation, we have a really good clinical trial called the LIGHT trial. This is the Laser in Glaucoma and Ocular Hypertension trial. What this trial looked at is, can you use SLT as first-line therapy for glaucoma or ocular hypertension versus our gold standard eye drops or timolol? They followed these patients over many years, and what they found is not only is SLT effective as a first-line therapy for glaucoma, but it's also cost effective, and it also reduced the risk of needing to go on to bigger surgeries. This trial alone has changed the way that many of us glaucoma specialists think about treating our patients, and it has put SLT as a great first-line therapy for open-angle glaucoma. Going back to narrow angles or closed angles, we also have a trial looking at laser peripheral iridotomies. I'm curious, has anybody in the room been diagnosed with narrow or closed angles, and instead of having a laser, did they have cataract surgery? We've got one. We've got two. There's a reason for that. In people with narrow or closed angles, it's usually because there's not enough space inside of the eyeball. That's why we have to poke a little hole in the iris to create more space. But one thing that's inside of the eye that takes up a lot of space is the lens. The natural lens in the eye is what turns cloudy with time, and that's what we call a cataract. And at the time of adulthood, the normal lens is about 4.5 to 5 millimeters thick. When we remove that and replace it with a clear plastic lens like we do at cataract surgery, how many people have had cataract surgery? Many, many, many. When we replace that cataract with a clear plastic lens, that lens is only 1.5 millimeters thick. So we've created a lot more space by getting rid of that natural lens and putting in an artificial lens. And what we've learned over the years is that that's an even more effective and long-term better solution for many patients, assuming you are old enough and have a cataract, for the treatment of closed-angle glaucoma. I'll leave it at that, and we can talk about that more offline if you'd like. So those are the two ways that we increase the outflow through the eye. We open up the drain. But what about turning down the faucet with lasers? Has anybody had something called CPC or ECP? We've got some. These procedures, the full name cytophotocoagulation, effectively just means that we're burning the ciliary body, which again is that thing that produces the fluid. We burn it to get it to turn down the faucet. We basically make it so that it's just not working as well as it used to. And there are a lot of different variations of these laser therapies, but CPC, ECP, micropulse CPC, they're all very similar in that they're using laser therapy in order to turn down the fluid production inside of the eye. These are very effective therapies. They do tend to create a little bit more inflammation, so it's rare for us to use them early in the treatment paradigm, although with innovation, some of these are becoming a little bit gentler on the eye and are being used a little earlier on. So what if laser isn't for you? Who here has been to the operating room? A lot of us. There's a lot of different surgeries. Who's had MIGS surgery? Who's had bleb-based surgery like a Zen? Who's had a tube or a trab? Lots of people. These are real surgeries, and as you can see, there's so many different options. So how do we actually figure out which one's right for which patient? Well, let's talk about MIGS. There's a million different ways to unclog a drain, and minimally invasive glaucoma surgery is all about unclogging the drain inside of the eye. Don't tell my wife, but this is an actual picture of our drain. So how do we unclog it? There's a bunch of ways, right? We can do what's called a trabecular meshwork bypass stent. Who's had an eye stent or a hydrus? We can do something called a goniotomy or a trabeculotomy. Who's had a hook dual blade or Omni or eye tract? We can do what's called a canaloplasty. Omni, eye tract. Viscodilation. Again, Omni, eye tract. Let's talk about what they are. And let's look at it based on their pictures. So a trabecular meshwork bypass stent, which is a hydrus or an Omni, hydrus or an eye stent, is where we literally just bypass it. It's like sticking a straw through these little holes in the shower drain. There's no hair clogging it anymore because fluid can flow through that straw. A goniotomy is where we just take off the whole cap. A canaloplasty is where we rotor-rooter it. We shove something in there and we snake the drain. And a viscodilation is Drano. These are all wonderful therapies because what they do is they take advantage of the natural drain of the eye. We leave all of the other anatomy intact and we just try and rehabilitate the drain inside of your eye. So if you hear the term eye stent, hydrus, omni, eye track, Cahook dual blade, Scion, they're all just fancy names for unclogging the drain. You're always going to hear different names because there's a lot of innovation in this space. And with innovation comes new names, which creates confusion, but keep it simple. You're unclogging the normal drain. But what if the drain just doesn't work? Let's say you just bought a 200-year-old house and they never clean those drains and they're fully clogged. They can't even stick the snake through it because it's just so calcified. Well, at that point, we have to replace it. One way we can do this is with minimally invasive bleb-based surgery. Has anyone here had a Zen? We have some Zen in the room. A Zen is a great device. What this device does, it's this tiny little thing. It literally looks like a noodle. And it goes from inside the eye to underneath the conjunctiva, which is that clear coating that covers the white part of the eye. So fluid flows from inside of the eye to under the conjunctiva, creating what we call a bleb. A bleb is a little fluid-filled pocket. The beauty of the Zen is that it's small. It's 45 microns, which is really small in diameter. So fluid can flow through it, but you have less of a risk of the pressure going too low. As glaucoma specialists, we tend to be less scared of really high pressure than we are of really low pressure. The Zen is a nice procedure that typically takes less time during the surgery than some of the bigger surgeries, but can get your pressure down pretty nicely. But what about the big guns? Some people here have had the big guns, I imagine. The big guns, the tubes and the trabs. If we need your pressure low enough, sometimes we have to go to the big guns. Tube shunts and trabeculectomy are the two procedures that fall in the category of incisional glaucoma surgery. These are procedures where we make bigger incisions in the eye. We either implant some hardware in the case of a tube shunt, or we create a hole in the case of a trabeculectomy in order to bypass the normal drain of the eye. In other words, that drain is broken. We can't rehabilitate it with MIG surgery. We need a lower pressure than we can get with a Zen, so we're going to the big guns. Now, these procedures tend to lead to the lowest pressure after surgery. However, nothing comes without risks. In these bigger surgeries, we take on more risk. You as a patient take on a little bit more risk. There's a risk of bleeding, infection, swelling. The pressure could go too low. The pressure could go too high. It might just not work. We're good plumbers, but we can't control how biological tissue heals. I wish we could. That's the holy grail. But when your glaucoma is to a point that you need a low pressure, the more risk, the more reward. And that's where those big surgeries come in. Every patient's glaucoma journey is different. I would implore you to ask your doctor if you haven't had SLT, if you haven't been offered some of these surgical procedures that you feel you may actually be a candidate for, just ask about them. Because every patient deserves the right to have a low pressure in their eye without all of the side effects associated with the eye drops, if it's applicable for them. Having surgery doesn't mean that you're going to get off of eye drops forever. But the way that I think about eye drops is that they're often a bridge in between interventions. And that's the way a lot of us are starting to think, so that we can keep your lives happy and healthy without having to use your drops 3, 4, 5, 6, 7 times a day, dealing with red eyes, teary eyes, and blurry vision. Thank you all very much.